proteins alone, but how proteins actually tie in with DNA and RNA. So that what I highlighted there is that, first of all, as I showed you in that earlier example, DNA and RNA don't always correlate with protein, but more importantly, the three of these together can inform better cancer diagnosis and treatment. So we're going to be seeing this in the very near future, even if it's not necessarily available to us right at this moment. So you saw this slide earlier, and I want to just point out that I highlighted this a little bit earlier about germline versus somatic. So let me just remind you what we're talking about when we talk about the germline versus somatic in cancer, because I know not everyone on this call is an oncologist like me. So germline in the orange there means that you inherited a mutation from your mother and father. And maybe the most famous recent example is Angelina Jolie, the actress, inherited a bad gene, a mutated BRCA1 gene from her mother, who died of breast cancer early. So if you inherit one of these genes, you have a very good chance of getting a second hit and developing breast cancer. That's why women who carry BRCA1 mutations have a very high risk of getting breast or ovarian cancer. And as you know, Angelina Jolie chose to have prophylactic mastectomies and oophorectomies. So that's on the left. On the right are what we usually are seeing in cancer, which is somatic mutations. And if you just look at the later somatic mutations, that's where you inherited normal genes from your parents, and you somehow knocked out both genes. You smoked cigarettes and you knocked out the same gene in your lung tissue, and you developed lung cancer years later. So I'm just reminding everyone here, the germline risk is a lifetime risk, whereas the somatic is associated with the exposures that you have in your life. So in thinking about germline disease, one of the questions is, right now, as oncologists, I'm an oncologist, I only see the patient once the patient has cancer. Isn't that too late? So one of the values of germline risk, for example, in the case of Angelina Jolie, is if you know you have a genetic predisposition, you can intervene before you develop the cancer. Isn't that better? And the answer is, I think it is. And certainly in genes that we know have a very high penetrance, very high risk of developing cancer, you want to intervene before that time. And one of the things we've learned over the past few years, and there have been several studies, this one from the Mayo Clinic breast cancer, it's a prospective registry. They screened up almost 4,000 women with breast cancer, and they just simply tested them all for these germline risks, these genetic inherited risks. And if they used standard guidelines like NCCN guidelines, about a third of these patients would not have been screened at all, suggesting that maybe we should be screening everybody. That, like for example, people don't know that their mother might have had breast cancer. Sometimes people are adopted. A lot of families don't have very good family histories, but about a third in this study were actually would have been missed if they didn't test everyone. And this was an even broader study from Mayo, where they didn't even screen by breast cancer. It was everybody who came into the cancer center. And they screened everybody for 80 genes that are known to predispose to cancer risk. And about 13% had a pathogenic germline variant. That means they had one of these risk factors like BRCA1 or 2, but half of them wouldn't have met screening guidelines. So anywhere from a third to a half of people who come into a cancer center don't have the family history to justify screening, suggesting again that maybe we should really be doing universal germline testing. It's controversial, don't get me wrong, and we could talk about it in the Q&A, but the idea is that maybe we're missing a lot of these germline risks. So one of the things that we're doing in my company now is we're sequencing the medical exome. So instead of just doing a panel like you see 113 hereditary cancer genes, just like I said with the somatic, with the tumors, you can actually sequence the medical exome. That means the germline DNA, you can sequence all the known genes, 6,000 known genes, and you can do that and biobank them. Why would you want to do this? Well, because there's a lot of other uses for those germline variants, like for example, pharmacogenomics, or you may have other cardiovascular risk factors or polygenic risk scores. So there's a lot of use for this. People are very sensitive about their germline DNA. I understand that, but we are coming to a point where oncologists and non-oncologists, internal medicine doctors, should be understanding kind of the scope of that person's DNA. And while we still don't know what most of those genes might mean or might do, I think, to me, as a researcher, the only way is to do this type of research up front so that we bank all this information and we learn as we move forward. So what does all of this mean without data? without electronic medical record data, without paper charts, but certainly you want what happens to these patients, because genetic information has very little value without clinical data. So what's the problem? Well, we know that there's no easy way for clinicians, even with these very fancy medical record, electronic medical record systems, to get quick, reliable answers. My computer record in my hospital is basically everything's in one place. It's better than a paper chart. I can find it quickly, but it's basically information in silos within a single computer system. And trying to put those together is very, very difficult. So if I had a question like, how many patients have stage 4 lung cancer with a P53 mutation who received second-line immunotherapy, and how did they do? I have to go into each of these different colored boxes in the chart or somewhere else. And a lot of times, like genetic testing in my hospital used to be in media tabs, PDFs, which are, the worst thing for research, the worst, because they're hidden in a place where you can't get the structured data. So this is the problem today, and that is a problem, because what we really want to do is start to pull this data and put them into structured fields. And a lot of companies are doing this, a lot of academic centers are doing this, but the fact is that it's a huge challenge because there's petabytes of data out there, and what we're trying to do is put it all into structured fields so that we can tie it to the genomics, so that we know what happens to these patients. And there are a lot of different ways to show this, and this is just a quick dashboard of how you can look at the patients. What kind of patients do you have? What kind of molecular abnormalities do they have? What kind of exams have they had? What type of drugs did they receive, and what are their outcomes? So you can do what might have taken a student years to do in a project with 100 patients. Now you can do them in thousands of patients, even within your own hospital. And there's so many ways that this data can be valuable. I focused on the clinical genomic database, but if you're a hospital administrator, you can track the quality of your care. You can visualize these patients in tumor board. You can if you're seeing a patient, you can say, how many patients like this have I seen with this mutation? And you can see what happened to those patients. You can find clinical trials. You can match them to trials, and you can conduct real-world evidence research. This journal is focused on clinical research. This is the kind of research where you're learning from every patient, not just for patients who go on clinical trials. So just here's an example of what's called a Sankey plot. This is we basically annotated all the patients at Mount Sinai, my hospital, using this machine learning approach, and we asked, what do they get first, second, and third line in terms of treatments? And you can see that you can actually see what kinds of patients they primarily they get. They get androgen targeted therapy, chemotherapy, and others. And then you can also see what they go from in terms of first line to second line to third line. It's kind of an ability, and these are all discrete fields, so you can actually click on them and you can actually see each individual patient if you want. So what are my conclusions? I know I went through this very quickly because I obviously want to be able to have more of a conversation and talk a little bit more about what where the field is going, and hopefully involve many of the excited medical students and residents and trainees and fellows and everyone out there, and as well as some of the professors who might have joined. How do we start to get to this future? Well, I think I hope I convinced you that genomic biomarkers are definitely increasing in number and complexity. That's already here. It's only going to get more complex. And I think hopefully nobody's really ordering single gene tests anymore. You're starting to be able to order more complex genes. I know, again, there's some resource issues in some countries, but the fact is that the cost of sequencing is going way down, and even some of these multi-panel tests are becoming cheaper than doing 3 or 4 or 5 serial single gene tests. And comprehensive molecular profiling, or CMP, with germline DNA, somatic DNA, and RNA, with the whole exome, each add insight. For example, if you do whole exome and germline, you get better detection of what's called tumor mutational burden, which is basically a predictor of benefit from immunotherapy. RNA-seq is better at identifying gene fusions, which might make the patient a candidate for specific drugs. So CMP should be considered a standard of care for cancer patients. Which test you order, how it's done, who pays for it, those are all difficult and important questions, but as much as possible, you should be ordering comprehensive molecular profiling for your patients. And then there's so much coming. It's so exciting. It's really, the problem, as I said, is really not going to be a an information problem, not going to be a testing problem. It's going to be an information problem. There's new genomic technology, new proteomic technology, and it's going to improve cancer care. I'm 100% sure of it because we don't understand cancer. We still don't understand what drives most cancers. And then finally, I showed you some data on abstracted clinical data from EHRs. None of these genes mean anything outside of the patient. The genes only matter because they interact in the patient, and the patient develops pain or has trouble breathing or dies of cancer. That's the only thing that matters. But because for many years we had no therapy or lousy therapies that kept the cancer at bay for weeks or maybe a few months, we have to go into understanding the biology, but we also have to understand what happens to these patients. And abstracting clinical data from EHRs using machine learning is going to enhance that data, genomic data, but it's going to bring us to another level if we don't depend on human beings to do this. We have to use machines. We have to use, there's so much data out there that we have to move to this machine learning approach. So what is our present state for precision oncology? Well, we do somatic tumor testing. Most people are ordering limited gene panels. There's actually quite a lot of data that a lot of patients are not getting tested at all, which is a terrible thing. And this includes the United States and Europe and Asia and many other continents. There's just not enough testing. Germline testing, a lot of cancer doctors are afraid to test for germline. They're like, this is not my business. I don't need to worry about the daughter of my patient or the son of my patient. Well, I would argue you should care about this, and you should at least introduce it because you as a physician are always very powerful. Patients will follow your advice. And many companies, including ours, will do all of the service work to make sure that the patient gets the appropriate genetic counseling if the doctor doesn't feel comfortable with it. But we have to learn how to do this. I would argue maybe in the future, this group could create some education courses around how to counsel patients around germline testing in cancer. I think it's very important. And I wrote clinical chart reviews by medical students. That's a little bit of a joke, but usually it's medical students who are doing this work. We know the attendings don't tend to do this because it's grunt work. It's a lot of hard work. You get a stack of charts. I did that when I was a medical student. And now you have EMRs, but it's the same idea. You want to get past this. You want to move to a place where we're not doing chart reviews. So I call it the present and future. Well, we're going to expand the type of testing. So you should do more broad testing, whole exome, whole transcriptome, and in the near future, proteomics. I think I showed you data from Mayo Clinic, and also there's similar data from Memorial and other places. We should be doing germline testing, in my mind, in all cancer patients. And we should stop relying on medical students to do this grunt work and start using machines to do some of this. And then the students can help by cleaning it up because you know what? We're still better than machines. Machines might be better at chess than me, but we are better. We are computers, right? We're synthesizing the data. The problem is at the end of a day of seeing 20, 25 patients, there's only so much that you can keep track of all that information. So the more we can use computers to basically be our helper, be our tool, the better. And I didn't talk about this today, but what do you do with all this information, the genomic data, the RNA, the protein, and all this clinical data? Well, in the future, not just being able to see the data in some of the ways I showed you, but data scientists are going to help us build algorithms. At Semaphore, we have 1,100 employees. 160 of them are data scientists. To kind of what we want to do is start building algorithms. And again, great centers, Mount Sinai, MIT, Stanford, everyone's trying to build this, whether in a company or whether in an academic center. But we have to build algorithms that take all this data and deliver it to us as clinicians in a way that we can then say, we should use treatment X, not treatment Y. We should do this test for this patient and not that test. Or we should leave this patient alone, he'll be fine with no treatment, or this patient, we should go in and do everything we can. Those are the kinds of data that we need to be better doctors, rather than me say, I saw a patient like this a few years ago, that's what we should do. So this is my email, william.oh@semaphore.com. I also have a Mount Sinai email, but please feel free to contact me if you have any additional questions. But I'm going to stop there And I think we'll have time for some questions. Thank you very much.
Thank you so much, Dr. O, for that engaging talk. And we do have a couple questions. We've had questions during this whole time just coming in. So I would like to just try to get to some of them right now. Our first question would be, what are the active use cases, applications on multiomics in cancer care or clinical research?
Well, I think that's a great question, and they're two different use cases. Research, basically the sky's the limit, right? Because the goal is discovery. So let's say there are only a few hundred genes that might lead to a clinical decision with the drug that's available today. You could run a panel with a few hundred genes, but my argument would be that the future is going to find a few thousand different genes, and also how those genes interact in ways that are much simpler than much more complicated, but will give us an answer with genes of the future. So for research, I think we should be looking at everything. I think we should be looking at protein. I think we should be looking at whole exome. I think we should be looking at whole genome in the near future. To the first question, Jake, which is what's the uses now? Well, this is already in the clinic. I showed a few examples, but if a patient comes with lung cancer, for example, they can get EGFR, they can get ALK fusion testing, they can get narrow testing. And sometimes because things have to be done quickly, that's what some doctors will do. But I would argue that as the speed with which these tests are being done shrinks, because they're now being done faster and faster, that you just want to do it. I call it one and done. Sequence everything. Sequence the tumor, sequence the germline, get everything there, and then just see the parts that you need to see now. So we actually shield a lot of the information from the doctor, because the doctor can't go through 18,000 genes. They want to know the top genes. But later, that information is still available. You don't have to send it off for more sequencing. So in lung cancer and prostate cancer and breast cancer, we're using genomic data all the time. Do we have everything the way I showed it in that ideal state? We don't. That's why I said present and future. We need to upregulate and get the quality of genomic and clinical data better for most practices, both in the United States and around the world.
Yeah, and you were talking about present and future. And I guess in talking about the future, and this is a question that's coming from a lot of people too, is, today's talk, you've spoken about, the promise of precision medicine. But then for the future, how do you envision that pervading into other medical subspecialties, and how long? But really, this is a question that everybody's on the question on their mind, is the affordability of this, because that's the real hurdle that you have in a lot of these cases, is the affordability.
Yeah. Well, I think there's two parts to that question, which is, are the lessons that I'm talking about expandable beyond cancer? And 100% it is, right? Precision oncology, you could substitute the word medicine for oncology, and you can think of multiple use cases in cardiovascular disease, in autoimmune disease, in rare disease. And in fact, we're looking in all those places too. Like everything that I just talked about with regard to extracting data and doing certain kinds of, let's say, germline testing, can be applied to other disease states. So I don't think the principles I talked about in oncology don't apply to other fields. I think they're just farther behind in many other fields, because oncology, the data has to be used now. The drugs, as you saw from that first slide I showed, the drugs actually work only if you have that mutation. So in oncology, we're closer to it. To your second question, which is the affordability, I do think that's a big issue. But I'll point out that the testing is a tiny, tiny fraction of the cost of the drugs themselves. So we do have a problem in America in particular, but in the world, which is that care is getting too expensive. And these drugs, which are, many of them are very exciting and very great, there's disparities in people's access to these drugs. And so the disparities to access to the testing, like, okay, if there's a drug that's a great drug, but you can't get the test to find out if you're a candidate, then how does it help you? And then that's a real problem. Honestly, that's a real problem. So I'm not going to be able to cover that in the next minute, but I think let me give you one example of how a test can help somebody to give a very cheap drug. So PARP inhibitors, many of the people on this call know that PARP inhibitors have significant activity in patients who carry BRCA1 or 2 mutations. So in breast cancer and prostate cancer and ovarian cancer, if you carry a BRCA mutation, if Angelina Jolie ever recurred with metastatic cancer, right? If she ever did, she would be a candidate to get a very expensive drug called olaparib. There are others, but a very expensive drug. There's nothing wrong. It's a great drug, but that drug is 10, 15,000 US dollars a month. And she could afford it because she's wealthy. But if you're in a poor country and you were to test a person and find that let's say that woman has that gene, and you can't afford the drug, carboplatin, a very inexpensive drug, costs maybe a few $100s, maybe less. I think in my hospital costs $50 for an infusion. $50 versus 15,000. It's really quite dramatic. Carboplatin has comparable activity. Again, if you carry a BRCA mutation, comparable activity. So if you stop and think about that for a second, you may say, well, who'd be crazy enough to want a PARP inhibitor? Well, PARP inhibitors are pills. They may have a different side effect profile. So in a wealthy country where you have a choice, you may choose to get a PARP inhibitor. But if you don't have that kind of money, then knowing that you have that gene might prompt you to get chemotherapy that's generic, that might actually have a very dramatic benefit, but only for those people with that particular mutation. So I do think the affordability question will continue to be an issue, Jake. It's a good question. I'm not going to be able to answer it here. I can say many people and many companies want to be able to provide this to the poorest people in their country and certainly around the world. We can't do everything for everybody, but democratization availability is very important.
Yeah, when we spoke with Dr. Bruce Chasen a few months back, he said the same thing. He mentioned that affordability is really a challenge and a hurdle that we're going to be facing here. And just questions just keep pouring in, and I'm loving it because just everybody's so engaged. And I love that about this whole platform, what we're trying to do here. And in your presentation, you did mention NGS. And could you just, I guess, elaborate more on specimen handling and the preservation to allow NGS, and how do you envision these new therapies developing from this?
Right. So the beauty and why it's become scalable in a clinical practice is that you can do all of the testing that I talked about on paraffin and embedded blocks. So, being in paraffin stabilizes these samples, as you know, for years, and the quality of that DNA and RNA can actually last for many years. So you can actually use a sample from 5 years ago, and you can still get much of the data that I showed. Does the DNA degrade over time? It does. Is RNA more sensitive and harder to handle? It is. But every single thing I showed you is based on paraffin embedded wax blocks. So that means you can ship it around the world. I see patients that come to see me in New York who came from Morocco or came from Asia, and they're bringing their blocks with them. We have no trouble getting DNA from those tumors. There's also new things I didn't talk about, like liquid biopsies, getting DNA from the circulation. The proteome will have some of its own sample handling issues. But for the most part, the only way this kind of stuff works and scales the way we talked about today is if you can get sample relatively easily. And I'm not saying it's easy, but you're able to get sample from most tumors. And that's what we are finding. We can get adequate sample from 95% plus.
So now, in another question we got right now is, and everybody's just really engaging now, is that the immunotherapy has demonstrated promise in several cancer subtypes, but that is likely because good biomarkers have been defined. But what is your outlook on, say, solid tumors? And when can we have some similar rules in patients plagued by those type of cancers?
Well, so it sounds like there's a few parts to that question. First of all, immunotherapy, as everyone on this call knows, is one of the most transformational advances in therapy we've had over the past decade in cancer. But not everyone responds. Only about a third to maybe a half, depending on the cancer, respond. In many cancers, there's nobody responds, or very few people respond. So we're still dealing with 50 to 75% of patients who don't even benefit from immunotherapy. And it also does not cure most patients. The cancers do come back. So this is a perfect area for research for the many budding researchers here. to understand why that is. And there's obviously a lot of people are very interested in this question. So we have not solved the immunotherapy problem at all. We have not solved the issue of selecting patients optimally for immunotherapy. So those are all things that we still have work to do. In terms of solid tumor versus liquid tumor, in terms of early stage diagnosis versus advanced stage, I would say that genetics, genomics, proteomics will play a role in all of the above. Obviously, we still have multidisciplinary ways to treat cancer. Surgeons, when I was a medical student, just so everyone knows, and I know there are some surgeons here, some very good surgeons, including Dr. Nicholas, but I thought surgeons would be out of business by now. I thought, I watched too much Star Trek where I thought, we would figure out what makes cancers tick and, put some kind of wave some device over them and cancers would go away. But that is not the case. And we need outstanding surgeons, and we need radiation doctors, and we need medical oncologists to give drugs, and we need scientists to continue to study. So cancer patients, we know, do best of all types when you have a very multidisciplinary group that brings expertise from all avenues.
So this last question that we're going to be going, because we have to be respectful of everyone's time here. And again, I just want to give thank you for not only your time here, but also the time that I had with you on the podcast. And this is kind of like a question that we had on the podcast in which we more explored some of the human elements. But we have had many attendees either currently engaged in research or some contemplating whether to start. And this was a question I remember asking you a few weeks back. But what advice would you have for them?
Well, first of all, you have to go with your heart. By the way, I don't remember what I said to you, Jake. So I hope it's not different now. And everyone
still going with the heart,
okay.
Of course.
All right. Definitely listen to Jake's podcast, everyone. I really enjoyed speaking there, and I think we spoke for quite a while about my career. So if you want to hear a little bit more about that, I think I talked at length. But to answer your question, I think research is the future. I love research. I love taking care of patients, but if I only took care of patients, I wouldn't be as happy as a person. I was an administrator for a while. I was a leader. I ran a very large division of 100 faculty, and I built a cancer center with my colleagues. And it was very satisfying, but, not for everyone. And I stepped down from that role because, there's a point where you want to let other people move into those leadership roles. I didn't think, that's why term limits exist, right? You need new ideas. You need fresh people. If I was a chair for chief for 25, 30 years, make a lot of people on this Zoom very unhappy and that does happen. People don't leave. And I don't think you can be fresh and have new ideas if you don't move on. But research, because we will not solve any of these problems, research is the gift that keeps on giving. It is, this was Nobel Week. It's inspiring to hear what people do and what people learn. It's, a few weeks ago, the scientist who was studying RNA for vaccines, the basis for the Pfizer and Moderna vaccines, she was acknowledged. She and one of her colleagues was acknowledged, and she talks about how everyone thought she was, ridiculous, that RNA would never work as a vaccine, and because she persisted, not only are we all safer because they were able to develop these vaccines so quickly, but she was using science to drive it. So I think research may not be for everyone, and some people may feel that they're really good at it or not so good at it. It's very frustrating. Somebody told me that that's what the in research is for, because I had a bad day once. I had some experiment didn't work, and she said, that's what the in research is for. You got to keep doing it over and over. But in the end, I think it's extremely satisfying. I think it's important to find the right mentors. I think it's very important to understand what the big picture is, which is really related to, understanding science, in my case, for the sake of cancer patients. And I think if you always have that vision for what you're doing it for, I think that makes a big difference in motivation.
Well, we here at IJCR, and I believe I speak on behalf of everybody here, would just like to thank you again, Dr. O, for your talk, for your presentation, and also for just the support that you have towards research and the same initiative that we have here. And that's a mission for encouraging individuals to be involved in research, but also in publication. And I want to thank not only just you, but everybody of these attendees that we've had across all of our platforms. Again, we have many exciting upcoming events planned. Please follow us on all of our social media platforms as well. Thank you all. And just again, have a great week.
Thank you, everyone.
Thank you.
Thank you so much, Dr. Ross. Have a great day. Have a great day,
Thank you.
everyone. Amazing presentation.